Okay, thank you, Rich. I think that go ahead with the administrative stuff of disclosing that this is a recorded meeting. To give a minute to the providers, and then I will start.
Yes, thank you for joining the WPS open meeting today. For your information, this is being recorded and transcribed. I will go over some of the administrative tasks here. Please click on the mute icon on the MS Teams app or on your telephone or headset to avoid noise interference. When it is time to speak, you can unmute MS Teams or press *6 if using dial-in only, and make sure your telephone or headset is not on mute. If you have trouble unmuting, please click on the raise hand icon or press *5 if you're using dial-in, and that will alert me that you would like to speak. Make sure that your computer speakers are on mute when you're speaking so there's no echo. The meeting is being recorded and transcribed, as I've already said. To aid in transcription, please introduce yourself and disclose any conflicts of interest or acknowledge that there are none before you speak. And please follow up any verbal comments on the draft LCDs by sending comments at wpsic.com. Thank you.
Thank you, Rich. Then let's get started. Good afternoon. This is the proposed local coverage determination open meeting conducted by WPS. Today's date is October 22nd, 2025, and the time is 1 p.m. Central Time. My name is Dr. Juan Shenin. I'm one of the contractor medical directors with WPS, and I will be moderating the meeting. Before we begin formally, I will ask my colleagues at WPS to introduce themselves, starting with the contractor medical directors. Please present yourself.
Good afternoon, everyone. My name is Dr. Claudia Campos, and I'm a WPS Contract Medical Director. Thank you.
Hi, everyone. Good afternoon. First of all, I'm Denise Nachotsky. I am a CMD at WPS as well. My specialty is cardiology. I reside in Southern Delaware, and I would like to welcome all of you here and thank you for taking time out of your busy practice to participate in this meeting.
Good afternoon, I'm Dr. Joelle Vlahakis, and I'd like to echo just a big thank you to everyone for being here.
Thank you. Now will the policy coordinators please introduce themselves?
Hi, good afternoon. I'm Michelle McCary. I am the Supervisor of Policy and of ALJ.
Good afternoon. My name is Andrea King. I am one of the policy coordinators.
Good afternoon. My name is Tara Schrader, and I am also a policy coordinator.
Thank you. Please, the other staff in attendance, go ahead and introduce yourself.
Good afternoon. My name is Richard Staley. I am the Policy Administrative Assistant and running the technical aspects of this meeting. If you have any questions, let me know through the chat or through my email. Thank you.
Okay. Any others? Okay, let's go ahead then. Thank you all, and thank you for participating in the WPS open meeting. This meeting provides an opportunity for stakeholders to recommend changes, submit additional evidence for consideration, and present concerns regarding a proposed LCD. This is also an opportunity for the MACs to ensure understanding of the LCD within the stakeholder community. We appreciate all who are participating and for your efforts to follow the LCD process and to provide feedback to us on these important topics. We also appreciate your commitment on providing the best evidence-based care to the Medicare beneficiaries. All comments should be provided in writing before the end of the comment period, as well as any literature that was not included in the evidence review or new literature that has been published can be submitted to the MACs during the open comment period for consideration. Literature must be published in a peer-reviewed journal. We will now discuss the first proposed LCD for this meeting. Our first proposed LCD is DL40300, peripheral nerve blocks and procedures for chronic pain. Its comment period ends on November 8, 2025. The lead CMD is Dr. Campos. Dr. Campos, please go ahead and proceed with your presentation. Thank you.
Thank you, Dr. Shaney. Can you confirm that you are seeing my screen?
Yes, we are.
Thank you. So this is a multi-MAC collaborative policy and includes WPS, CGS, NGS, Noridian, and Palmetto. The LCD reviews the evidence for peripheral nerve blocks and other procedures by condition and establishes limited coverage or non-coverage based on the available evidence. Evidence was synthesized and grading of recommendations, assessment, development, and evaluation grade approach, and summarized in the overall conclusion section and the tables for each condition within the LCD. A CAC meeting was held on February 3rd, 2025, and the areas in which the policy agreed and disagreed with subject matter experts are summarized in the LCD. Sorry, can you see my next slide?
No.
Still seeing the original slide.
The original, sorry. I'm gonna have to stop sharing and retry. Sorry, Rich, do you mind advancing on your end or pulling it up since?
Yes, I'll pull it up on my end.
Okay, sorry, thank you. And while you do that, on slide 2, the LCD utilizes a threshold of at least moderate certainty evidence for coverage consideration. The very low certainty ratings across comparisons indicate substantial uncertainty about the true effectiveness of these minimally invasive interventions.
The DUR as well as PNT.
Could someone please mute their phone?
Actually passed a law, and I believe it was last session, it had been the session before, I really remember, but they passed a.
You may continue, Dr. Campos.
Thank you. The very low certainty ratings across comparisons indicate substantial uncertainty about the true effectiveness of these minimally invasive interventions. As a result, any observed effects may not translate into meaningful benefits for patients. The balance of review findings indicates that the use of related minimally invasive interventions for the treatment of chronic non-cancer pain is currently not supported by high-quality evidence. Peripheral nerve blocks, RFAs, cryoneurolysis, when compared to current standard of care therapies, did not demonstrate consistent and sustained improvements in pain, function, patient experience measures, and medication usage by a clinically significant margin. Next slide. So this policy will replace nerve blocks for peripheral neuropathy L35222 that has been effective since 10/1/2015. This current policy is non-coverage. So this policy expands coverage to allow for 3 conditions in which evidence demonstrates that peripheral nerve blocks or procedures provide benefit, and other conditions remain non-covered. Next slide. Radiofrequency neurolysis for trigeminal neuralgia is considered medically reasonable and necessary when all the following conditions are met. Condition has been present for at least 6 months and is not responsive to medical therapy or intolerant to medical therapy, and the patient is not a good surgical candidate or declines surgical interventions, and the patient has had at least 75% improvement after a diagnostic trigeminal block. There is a frequency limitation, which is 2 radiofrequency treatments within a rolling 12 months. Next slide. Carpal tunnel syndrome. So corticosteroid injections with or without local anesthetics can be used for the treatment of carpal tunnel syndrome. Peripheral nerve blocks with local anesthesia are not indicated for the treatment of carpal tunnel syndrome, and peripheral nerve denervation is not reasonable and necessary. There is a frequency limitation of maximum 3 steroid injections per lifetime per side. Next slide. Morton's neuroma. So corticosteroid injections may be used for the treatment of Morton's neuroma with a frequency limitation of 2 steroid injections per lifetime per side. And moving on to our limitations on our next slide. A peripheral nerve block involves the use of an anesthetic and/or corticosteroid and does not include injections of biologic or any other injectants. During denervation procedures, patients with implantable electrical devices and intrathecal pump delivery devices, providers should follow instructions and planning as indicated to ensure patient safety. The use of moderate or deep sedation, general anesthesia, and monitor anesthesia is usually unnecessarily or rarely indicated for these procedures. Next slide. Other limitations, peripheral nerve blocks and procedures to treat complex regional pain syndrome, widespread diffuse pain, or systemic polyneuropathies are investigational and therefore are not considered medically reasonable and necessary. Same for dry needling or multiple injections with denervations providing during the same session. Next slide. And this is a comprehensive list of what is currently not covered in the policy with, next slide, some exceptions. During regional anesthesia blocks, during acute surgical pain, or pain related to malignancy refractory to medical management. Thank you. This is the end of the presentation.
Thank you, Dr. Campos. Greatly appreciated. Let's go then to the presentations. We have 5 presentations today for this LCD. Each presentation will be allotted up to 10 minutes. If a previous speaker has already made your point, simply state that you agree. We would like to give everyone an opportunity to speak. Prior to presenting or commenting, please introduce yourself, state your affiliation or specialty, and indicate whether you have a conflict of interest and what the conflict is. So let's start with our presentations. The first presenter is Dr. Kevin Barrett from the International Pain and Spine Interventional Society. Dr. Barrett, please introduce yourself and state any conflict of interest.
Perfect. Thank you so much. And I apologize. I know we have a limited amount of time, so I'm going to be going pretty quickly through this. I apologize for speaking quickly, but this is a pretty large LCD. But I'm Kevin Barrett. I'm speaking on behalf of the International Pain and Spine Intervention Society. I'm an interventional pain, physical medicine, and rehab doctor. Next slide here. I do paid talks for a procedure called Intracept sometimes that is not related to this LCD, so I don't have any directly related conflicts of interest. Next slide here. So the proposed LCD broadly eliminates coverage for procedures integral to the practice of multiple specialties and for multiple significant chronic pain conditions. Next slide here. So we're currently asking that the MACs rescind the LCD. We feel it oversteps federal agency goals outlined by the CDC and HHS, which we'll get into in a little bit. And alternatively, if this is not immediately rescinded, we would recommend and hope that we could.
I'm sorry, could someone please mute their phone?
We would recommend postponing issuance of the LCD to collaborate with societies on developing more evidence-based guidelines. Next slide here. Next slide here. So obviously the chronic pain population is a big population, represents about a quarter of the US population. Next slide here. Next slide. Yeah. Great. So the CDC guidelines, basically on the last slide, had recommended a multidisciplinary approach, multimodal approach to pain management. HHS took that a little bit further and actually recommended access to other therapies, including neural blockade and radiofrequency ablation, in order to prevent some of the opioid issues that we're seeing in our country at this time. Next slide. Alternative treatment options are pretty limited for this patient population. Next slide here. Next slide. So peripheral nerve blocks and radiofrequency ablations have decades of clinical use, supported by peer-reviewed literature, demonstrate well-established mechanisms of action, and have favorable safety profiles. Next slide here. Many of these peripheral nerve blocks and ablations are used to treat conditions that are too rare to realistically be studied in a well-powered RCT. And many of these have been standard of care for so long that it's hard to ethically do a randomized controlled trial in these patient populations. It's not entirely reasonable for most of the patient populations that are affected to have the same level of evidence for more common chronic pain conditions. Next slide here. The risks of eliminating peripheral nerve blocks and ablations are obvious: potential increase in opioids and more costly surgical interventions. Next slide. Next slide. So I do want to say I'm going to separate peripheral nerve blocks and peripheral nerve ablations from genicular nerve block and genicular nerve RFA. As an interventional pain doctor, it does not make sense to me that these would be in the same LCD. They represent fundamentally very disparate issues here. Peripheral nerve blocks and RFAs are used for fairly rare conditions or complex medical problems that we don't really have a whole lot of options for, whereas genicular nerve blocks and subsequent ablation, this is part of a well-defined treatment algorithm that's comparable to our management of low back pain, where you do medial branch blocks and medial branch RFAs. It's the same thing, but for the knee. So it does not make sense that they're in the same LCD. So I'm going to treat them separately, which makes getting this into 10 minutes even more challenging. But next slide here. So the proposed LCD regarding the occipital nerve blocks does acknowledge generally favorable systematic reviews. It really highlights a study by Malekian et al., which showed no significant difference between treatment and sham with regard to severity and duration of migraines. Importantly, failed to mention that there was a significant decrease in the frequency of migraine episodes. So if you ask anyone with a migraine's a migraine. They're severe, they're painful. You end up going to the hospital sometimes for migraines. Decreasing the number of migraine episodes is really one of the mainstays of treatments, and occipital nerve block has been demonstrated to do that. Next slide here. There are limited options for this challenging population. Inexpensive, safe procedures. Limiting access will almost certainly lead to an increase in expensive medications, ER visits, urgent care visits, and other expensive, more invasive procedures. Next slide here. So we're going to talk a little bit about complex regional pain syndrome. This is a poorly understood, rare, but debilitating painful condition for which we have limited options. It involves phases of intense pain mediated by sympathetic nervous system. And one of the mainstays of diagnosis and treatment really for many, many decades has been stellate ganglion blocks. So the proposed LCD really describes 2 systemic reviews as the evidence against stellate ganglion blocks. Notes that there's heterogeneity within the study population. If there's heterogeneity within the study populations in a systematic review, you kind of have to evaluate the individual studies, and they don't evaluate any of the individual RCTs. So next slide here. We do have limited evidence from RCTs. I agree with that, but this procedure has been around since the 1930s for diagnosis and treatment of CRPS. Obviously, the terminology has changed, the techniques have changed, but it's challenging to perform an RCT on a relatively small patient population, especially when the procedure has been standard care for many, many decades. The LCD also describes some misunderstanding in general of what's happening in a stellate ganglion block, undesirable effects, which basically are describing Horner syndrome, which would be expected. Also, the LCD doesn't describe some of the clinical guidelines which have been posted, which have been published. Harden et al. 2022, which recommends stellate ganglion block as a first-line treatment. You take away the first-line treatment, what comes next? The second and third-line treatments: neuromodulation, intrathecal drug infusion, sympathectomy. Almost certainly eliminating stellate ganglion blocks is going to increase medical cost. Next slide here. Next slide here. So there are guidelines, and I'm going to quickly just kind of throw these slides up. I think we sent you most of these guidelines with Benson et al. Published this year, multi-society, multidisciplinary guidelines. Next slide here. Next slide here. And one more, next slide. Just in brief, to highlight here, great occipital nerve blocks, moderate level of certainty that they are efficacious, same with stellate ganglion blocks. Next slide here. I do want to highlight right here, based on the peer-reviewed published literature, trigeminal and pudendal nerve blocks, conditional recommendation, so a lower level of evidence. This is really in direct contrast to the proposed LCD, where trigeminal nerve blocks are one of the few covered procedures. So there's obviously a discrepancy between the experts in the field that are publishing in the literature versus the recommendations in the LCD. Next slide here. Next slide here. So there's some terminology nomenclature issues. Thoracic nerve root blocks. This doesn't really mean anything. Thoracic nerve root block to me would mean a thoracic spinal nerve. However, the LCD describes intercostal nerve blocks based on the evidence I could read there, so that needs to be clarified. Also describing any other peripheral nerve blocks or denervations not listed above. Any other peripheral nerve means the entire nervous system distal to the central nervous system, so distal to the spinal cord. That could be interpreted many different ways, so that's kind of an umbrella term that could be confusing. Next slide. Pulsed RFA is not thermal RFA. Next slide here. I don't have time to talk about that, but I think we're sending you a letter. The proposed LCD, next slide, thank you. The proposed LCD is unlikely to reduce wasteful expenditures. This is a relatively rare subset of patients. I went through all the Medicare data from 2024, 26 million for all of these peripheral nerve blocks and ablations, relatively small monetary value. Next slide here. The other options are costlier. We want to work with you to develop evidence-based frameworks. Next slide here. So now we'll get into genicular nerve blocks. Next slide. So this is one that is really, unfortunately, we don't feel the proposed LCD accurately addresses current evidence, relies on one primarily systematic review, which is inherently flawed by Almeida et al. It's interesting, American medical policy is kind of being dictated by one systematic review that doesn't have a single American author. I went through every systematic review. This is one of the only ones without a single American author. This is a study out of Brazil, pooled trials with different procedural targets. It would be akin to saying that stenting doesn't work, because when we did angioplasty without stenting, it wasn't helpful, so stents don't work. Our procedural targets and lesion sizes have evolved, our understanding of this over time. And when we actually look at the data, subdividing different procedural strategies, next slide here, we can see that if we optimize procedural strategies, we get better outcomes. Next slide here. So the most rigorous up-to-date systematic review, which is an American study, University of Utah and University of New Mexico, did demonstrate effectiveness of this procedure, especially when you subdivide into procedural techniques. Next slide here. So higher success rate when you're ablating 3 or more nerves, larger lesions. Next slide here. And since our evolution of the procedure has happened over the course of the past few years, we have seen RCTs come out demonstrating more consistent effectiveness. So 2 RCTs just came out that are not included in the LCD. This is one here. Next slide. This is another one. I've included those. I can't get into the weeds of it. Next slide here. Next slide here. There is multidisciplinary, multi-society support for genicular nerve RFA. Next slide here. And next slide here. Again, I don't have time to go into these, unfortunately, but there are some forthcoming guidelines which are multi-society, which have been in the works for 2+ years, demonstrating specific techniques, specific inclusion criteria that are going to be published soon. Next slide here. Next slide here. Unintended consequences are almost certainly going to happen. This is a safe, effective procedure. Next slide here. Increased opioid prescriptions will likely come out of reducing coverage for genicular nerve RFA, unnecessary total knee arthroplasty, revision surgeries. Next slide here. I think this is really important. Again, I went through all the numbers from 2024. Knee arthroplasty, $710 million a year in 2024 versus genicular nerve block and RFA at 18 million. The numbers for expensive surgical interventions will almost certainly go up. What do you do if you have a knee replacement and you still have knee pain? Genicular nerve blocks and subsequent RFAs thereafter are a well-defined, appropriate, and successful treatment strategy that is cost-effective from a Medicare standpoint. Next slide here. Next slide here. So our conclusion, again, we feel that the LCD does not reflect the current evidence. If this isn't rescinded, we would like to work with you on developing more appropriate guidelines. At a minimum, separate genicular nerve blocks and RFAs from peripheral nerve blocks and RFAs. These are fundamentally different things for very different patient populations. And we really feel these are directly contradict HHS and CDC's published goals on eliminating opioid use and abuse in this country. You can go to the end slide here because there is a question thing which has some contact information. Again, really appreciate your time. Thank you for the opportunity to speak. I'm sorry I was speaking really quickly. We have a letter with all of this outlined, but this is a very important thing that will impact many, many people if this is not rescinded. There are limited options for these patient populations. Thank you.
Thank you so much, Dr. Barrett. We really appreciate your presentation and your deference to our time limit. You have until November 8th to provide any additional comments and clinical literature to our policy comments at WPSIC.com mailbox. So we appreciate the presentation. We had that presentation, but you can submit any additional comments and documentation to the mailbox I mentioned.
We will. Greatly appreciated.
So thank you again. So are there any comments on the presentation? Okay, hearing none, let's move then to our next presenter. Our next presenter is Peter Brady from Pacira Bioscience, Inc. Please, Dr. Brady, present yourself and state any conflict of interest and proceed with your presentation.
Hello all, can you hear me?
I can hear you.
Okay, wonderful. I'm Peter Brady. I'm an anesthesiologist. What we're here to discuss is cryoneurolysis and the management of pain with osteoarthritis of the knee. Next slide. As far as any disclosures, obviously I do work with Pacira on various things, educational opportunities for other physicians and further developing this technology. But what is cryoneurolysis and iovera? iovera and cryoneurolysis is a handheld device that provides drug-free, long-term pain management that is done through a freezing process. It is recognized by CMS as part of the No Pain Act, which is an act that went into effect in January of this year, and it only recognizes 11 devices as being efficacious and to be reimbursed for acute pain management to reduce opioids. Next slide. Just real quickly to kind of explain the spectrum of where this fits in. Like our prior just presentation, cryoneurolysis and radiofrequency have a similar mechanism. They work very different ways. They have different side effects, different benefits, different disadvantages. But they both work with the denervation of nerve endings. And when the nerves are denervated, they do no longer obviously transmit pain signals to the brain. And this is a way of addressing chronic pain, as well as in cryoneurolysis, acute pain as well. The only other thing to point out here is there's yet another technology called cryoablation. This will come up later in the LCD when one of the articles that's listed is a cryoablative procedure. Cryoablation procedures are not denervation procedures. Cryoablation is used for cancer therapy. Next slide, please. The process that occurs with cryoneurolysis at the temperature of nitrous oxide, basically it's a neurolytic process that involves only parts of the nerve. It's the axon, myelin sheath, and Schwann cells. It preserves all the structure, the blood vessels, everything surrounds it. So when the nerves regenerate, they regenerate exactly within that connective tissue structure and reinnervate their endings, their nerve endings, when the regrowth or the regeneration is complete. Next slide. There is lots of clinical support for iovera cryoneurolysis in both the chronic as well as the acute pain field. Again, it's a reversible axonal injury with full nerve regeneration. It's somewhat analogous, as I mentioned, to the radiofrequency. The actual mechanism of action is similar. The techniques are very different. The technology is different, but they both achieve long-term denervation with localized image-guided neurolysis of specific nerve endings. The clinical evidence in support of iovera is strong. And we see that both in postoperative knee pain as well as in chronic pain conditions, and it's an opioid-sparing relief and facilitates an improvement in mobility and recovery. The mechanism itself is extremely well defined. The technology is well defined and established. The safety profile is great. The efficacy is great. It's fully in line with CMS non-opioid management objectives, cryoneurolysis is medically reasonable and necessary, and we hope that we find that this LCD is thrown out. Next slide. In addition to having, in addition to having clinical support in the literature, there are various societies that have supported it as well. The American Academy of Orthopedic Surgeons have supported denervation therapy as a means of reducing pain and improving function for patients with osteoarthritic knee. And it's based on a Radnovich study in 2017, which is deemed high quality. And that was a cryoneurolysis study, which we'll see a little bit later. HHS has also indicated that there are numerous indications for chronic, intractable, painful conditions that can be responsive to neurolytic therapy like cryoneurolysis. And finally, the American Society of Anesthesia, they've also made mention that there are a select group of patients that can be very responsive to this sort of type of therapy, including post-thoracotomy pain syndromes, as well as peripheral nerve pain, which obviously would include osteoarthritis of the knee. Next slide. So this is the Radnovich study right here. It's again for osteoarthritis of the knee. It's a prospective, randomized, double-blinded, sham-controlled, multi-center study. Basically two groups, the study group, the control group. The control group is literally a machine that looks like a proper iovera machine, but it's strictly sham. It does not provide any form of cryoneurolysis. And obviously the cryoneurolysis group, the study treatment group, had one treatment, and that was the interpatellar saphenous nerve. The endpoint for this particular study was the WOMAC pain score at day 30, and they looked at secondary endpoints from 30, 60, and 90 days, including VAS pain and WOMAC functionality. Next slide. Next, yeah. This is the outcome from that study, the Radnovich study. They showed that at 30 days, there was significant improvement in WOMAC functional scores as well as VAS pain scores that far exceeded the establishment of minimal clinical important improvements. In addition, they show statistically significant greater reduction in WOMAC pain at 30, 60, and 90 days, and that's what you can see on the graph on the right. The reason the study is being brought up today is because this is one of the three that's listed in the LCD. The two concerns that were listed in the LCD with this study was one, that the criteria for demonstrating success was greater than 30% reduction in pain. They felt that criteria should be higher. What not really understood, and others will agree with this, in typical treatment of osteoarthritis, cryoneurolysis and radiofrequency ablation is not first-line therapy in most situations. Oftentimes when you deal with osteoarthritis pain, you are getting intra-articular injections of either steroids, hyaluronic acid, NSAIDs, now connective tissue matrix. These are the kind of modalities that are oftentimes used. It's only when all these intra-articular modalities either haven't worked or quit working for patients do we start looking at second-line therapy like interventional pain management procedures. And that is where this comes into play. So if you're actually looking at how is 30% good enough for somebody to show success, your alternatives are showing zero success. So what cryoneurolysis is doing is showing a tremendous benefit for a group of patients that no longer respond to other conservative therapy measures. Next slide. In addition, there's in 2019, there was an interagency report for best practices in pain management, and one of the conclusions was that CMS and private payers should cover many of these interventional pain techniques. And one of their statement, diagnostic and therapeutic interventional techniques can be valuable options prior to the initiation of extensive surgery, as well as during the initiation of opioid treatment or in concert with other treatment modalities. And the task force found that interventional pain procedures like cryoneurolysis deliver durable pain relief and reduce opioid use for acute and chronic pain. The LCD is trying to remove the indication for cryoneurolysis.
2 minutes remaining.
Pain. Next slide. The second paper that was listed was the IGOR study. That it's not a study, it's actually a registry. And go to the next slide, please. Their criticism of it was that if you look, there's IA means intra-articular, so there's various intra-articular injections and showing the success on pain severity. The cryo was not the highest rated, but once again, just like we talked about with the Ranovich study, cryo is not done as an alternative to intra-articular injections. It's done when intra-articular no longer works. So what we're providing is up to 60% improvement in patients who are no longer responding to intra-articular therapy. And so this is why the cryoneurolysis is so important in the management of people with more severe osteoarthritic pain. Next slide. And this is just to show that there's plenty of literature out there that shows it works in acute pain as well. Next slide. Some of the points to bring out, the LCDs seem to have different evidentiary standard coverage. There's a couple listed here that showed low to moderate, or they showed uncertain effectiveness and safety concerns. And for the Ranovich study, there's moderate quality of evidence supporting it. In addition, CMS has instructed insurers to have clear, randomly controlled studies with published peer reviews in order to show clinical decision-making and what they will cover and what they won't. Ranovich meets all these criteria with their moderate level of certainty, and therefore should be considered as a viable treatment for osteoarthritic pain. Next slide. Last thing, the last thing I want to bring out is the third study in the LCD. These are the three, is NIGARD. NIGARD shouldn't even be in here. NIGARD is...
And I'm sorry, sir, your time is up.
Thank you.
Thank you. We appreciate your presentation. Are there any comments from the CMDs? Okay, hearing none. Now we will continue with the presentations. I know that people have their hand up that they want to comment. We will let commenters on the presentation speak after the presentation. Currently, we are letting the presenters present, so we are not going to do our next presentation. Our next presentation is from Rajiv Tewari and Herman Kalia. They represent the Herman Kalia. in representation of the American Society of Pain and Neuroscience. I repeat, the next presenter is Herman Kalia from the American Society of Pain and Neuroscience. Please proceed with your presentation.
Yeah, thank you. Thank you for this opportunity. I'm Hemant Kalia, obviously representing American Society of Pain and Neuroscience. No conflict of interest. I would like to first thank the esteemed medical directors for this opportunity today to provide us, give this comments. Aspen represents more than 3,000 physicians across multiple disciplines, including but not limited to neurosurgery, pain management, PMR, anesthesia, neurology, psychiatry, and interventional radiology. Aspen vehemently opposes the proposed LCD, and you will see all those shades of dissent in our presentation today, including this dark theme on the PowerPoint slides. So, we all know that there are essentially three guiding principles or three documents or the policies which have been promulgated to create LCDs. First of them is obviously the Social Securities Act. The second one is the guidance from the CMS. And then third is our checks and balances, which is the Congressional Oversight Committee. And we know that we have gone back and forth on some of the amendments which were made on defining the criteria for reasonable and medically necessary in the Federal Register in 2022. So I will actually take a little bit different approach in my presentation. You will hear from my colleagues on the evidentiary part. I will focus more on the ethos and the pathos of an argument and leave the logos to my colleagues. I'll focus on the procedural aspect and the impact of this proposed policy on Medicare beneficiaries. Next slide. Let's start with, looking at the scope of the proposed policy. Next slide. By the stroke of a pen, the current MAC is trying to make these 11 procedures, which have been safely and effectively practiced for more than 4 decades, experimental and investigational. By limiting access to these safe and effective therapies, I believe the MAC is forcing Medicare beneficiaries towards more costly and high morbidity procedures like knee replacement surgeries, occipital nerve stimulators, nerve decompression surgeries, and so on and so forth, very nicely delineated by my colleague from Ipsos. You're essentially creating a dual Medicare system here. Next slide. So with this dual Medicare system, although the current policies and the law does provide a very small loophole to create this dual Medicare system, but it is unconscionable and unethical on the part of the MACs to exploit this loophole. The most recent DOJ report on the Medicare Advantage plans very nicely kind of delineated the challenges with which Medicare beneficiaries are experiencing on these plans which are administered by Medicare Advantage commercial payers. I believe the MACs are unfortunately doing exactly the same thing. And I wonder what DOJ and our legislators will think if we bring this to their attention that unknowingly or knowingly, these policies are creating a dual Medicare system where if a Medicare beneficiary who has this exact same condition, who's living in Florida, will be able to get the same procedure. But unfortunately, if they're living in any of these states covered by this multi-jurisdictional MAC, for example, I'm from New York State. So if a Medicare beneficiary is in New York State, just because of their geographical location, they will not be able to get access to these therapies, which is highly unconscionable. Next slide. There are also some procedural violations which have happened here. MACs I believe the first meeting happened on February 3rd, as shared with us in the very first few slides with the medical director. MACs were aware of few key publications coming out this year through the CAC process. In fact, one of the meta-analyses was just published on October 8th, which was referenced by my colleague, and we have sent the same in our letter as well. Several key manuscripts were excluded from consideration, and this LCD was rushed out. Next slide. If we specifically talk about the genicular RFA and the evidence around it, some of the guidelines, especially I'm going to focus on the ASPEN guidelines because that's the society I'm representing today. It provides a strong consensus. And if you look at that guideline, there are 24 authors who have published that guidelines, and the guideline has gone through a peer review process. In addition to ASPEN, as clearly delineated by my previous colleague presentation, there are other guidelines which support the use of genicular radiofrequency ablation. Unfortunately, the multi-jurisdictional medical directors have blatantly overseen the guidelines provided to by the subject matter experts in the field and promulgated this new guidance document across the jurisdictions. It is actually not only unconscionable, but actually disrespectful to the practitioners who practice the art and the specialty of interventional pain management. Next slide. So I'm not going to go into the details of all the other evidence which supports the use of radiofrequency ablation for trigeminal, occipital, pudendal nerve blocks, and Morton neuroma. My colleague from Ipsos has covered it really well. Next slide. I do want to emphasize on the consequences of this restriction if it goes to effect. It will provide denied access to these safe and effective treatment options which have been practiced for over 4 decades. It will push Medicare beneficiaries to use opioids and increase their dependence on these medications. We are just turning the corner on the opioid epidemic, and the MACs now are forcing Medicare beneficiaries back to the opioid reliance. They will also push Medicare beneficiaries to costly and more high morbidity procedures like joint replacements, and their ER visit utilization is going to go up pretty significantly. And not to mention the suffering, the pain and suffering which Medicare beneficiaries will go through due to lack of access to these safe and effective procedures. Next slide. So what's our ask? We urgently request all the MACs to immediately withdraw and rescind this specific policy and retire it. We, as you will see in our letter, we have sent our letter and addressed it to HHS and CMS. We are requesting establishment of a MedCAC for this. Obviously, the multi-jurisdictional MACs have clearly shown their inability to provide a document, a coverage determination document, which can follow the specialty recommendations. And they have blatantly overseen some of the not only international, but national recommendations for all these procedures through the societies. We also recommend engaging multiple societies through this process to develop an NCD for these specific treatments. And ASPEN, with other societies who are part of the multi-specialty pain work group, would be more than happy and willing to be a part of this process and guide CMS and MACs, if interested, to develop a meaningful coverage determinant for Medicare beneficiaries. With that, I'm going to yield my time so that we can have more discussion at the end for some of the authors who have published on this extensively. Thank you.
So thank you for your comments. Any comments from my fellow medical directors on this presentation? Hearing none, remind you that you can submit in writing to our comment mailbox and any peer review published evidence that have been published since the literature was done for this LCD. Thank you. So continuing with our agenda, the next presenter will be, give me a second here, it will be Neil Resnick from the Society of Interventional Radiology. And John Smirnopoulos, sorry about that. You can state your names correctly and any conflict of interest and proceed with your presentation. Thank you for presenting. Go ahead.
Thank you very much for your time and for inviting us to speak. One of the benefits of going, last or next to last in this case is that we've had some excellent presentations so far that have covered much of what we would, have also recommended. So I'll try to be very brief and again allow more time at the end for people to talk openly. If you can go next slide, please. Okay, next, you can, so just a brief introduction to us and IR. We're representing the Society of Interventional Radiology today, and we're a society of about 8,000 members, interventional radiologists. Our specialty is imaging guidance for minimally invasive procedures. Next. We treat acute and chronic conditions all throughout the body, work with nearly every specialty within medicine, and many to perform many pain procedures. Many of us take care of long-term patients in clinic, manage or co-manage a variety of diseases. Next. Okay, these are all the different fields we touch. Next. All right, next. Okay, so why do we treat pain? Of course, help patients and referrers. Next. Sorry, this would have been much easier if I could have control of this myself. For IR, we pride ourselves to be able to get a needle anywhere in the body, access to anywhere in the body with a needle or ablation probe. Next. Next. And we have access to advanced imaging guidance, so we get accuracy in our nerve interruption. Next. Next, and we have ablation tools that can lead to a durable analgesic effect, which has been well described up till now in many of the presentations. Next. Next. So it's pretty clear that everyone knows we have an opioid epidemic healthcare crisis. Here's some of the numbers from a couple of years ago. To the extent it's actually greater now. Next. CDC also and Health and Human Services have recommended procedures over opioids for management of chronic pain. Next. So really, it's all hands on deck here. That's why you've got multiple societies, presenting and saying that we really need to rescind this LCD. Next. So this is kind of our algorithm. You get the next as well. So when we're looking at how to treat pain, we tend to look at, can the nerve responsible be identified? If so, does it carry motor signals? And, we'll look to inject the nerve to more or less test the nerve as a block to see, the response. Hopefully that provides a relatively durable effect. In many cases, provides temporary effect, and it's helpful. But if we don't get a negative response to it, then we'll bring the patient back and perform nerve ablation. Next. 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 Okay, I really want to make a distinction here between nerve blocks and nerve ablation because these were really coupled together in this LCD. So nerve blocks, of course, are interrupt nerve conduction pathways that are responsible for pain. Next. And the idea is to reduce periprocedural pain. At least in many cases, that's what we're doing with these blocks, whether it be a hepatic nerve block prior to, say, a biliary tube placement or ablation of a hepatic tumor. Next. Here's an example of that, hepatic nerve block. Next. We do testing testing the target prior to nerve ablation. Next. Here's an example of intercostal nerve block prior to intercostal nerve ablation, if successful. Next. Next. All right, we usually use an analgesic and often potentiate it with a steroid. Next. We expect that effect to typically last hours to days, sometimes longer. Next. Okay, and this is a contradistinction to a nerve ablation, which is neurolysis, and during that we expect durable interruption and reset of the nerve conduction pathways, maybe deep in the body, right? Totally different mechanism. We expect a durable effect. Next. Okay, and it may be in the form of RFA, chemical neurolysis, say phenol or alcohol, or cryoablation. So we've heard presentations describing almost all of these. Next. 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 And we expect the effect to last weeks to months, sometimes indefinitely. Okay, with that, I'm going to turn this over to Dr. Smyrniotopoulos to talk about some of the evidence.
Yeah, thank you. I'm John Smyrniotopoulos with SIR. In terms of conflicts of interest, I have given lectures for Avanos and Boston Scientific, similar to Dr. Barrett for Intercept, which we're not discussing. So just to dive in a little bit of literature, we can't do everything here because obviously this LCD has a plethora of peripheral nerves that are listed, but we're going to go into medial branch nerves. There is plenty of data regarding medial branch nerves. It's a tested modality for block and subsequent ablation. It's part of the algorithm of back pain. It's a very specific point of back pain, posterior column, which is different than anterior column, which is different than radiculopathy. Let's go to the next slide. All right, and so we have guideline support from this, from societal guidelines, pain reduction that lasts weeks to months. This is category A evidence here. Go to the next slide, please. All right, so genicular neurolysis. This has been brought up a lot, and I think it's incredibly important because I think what it reflects is the number of patients that we see. Different societies, different people in their training pathways have all converged to this, and we all have seen this particular patient population, which means that it's true, millions and millions of people experience osteoarthritis. Not everyone can have surgery, not everyone should have surgery, and people that have had surgery may still have pain and are not able to have a reoperation, right? So you have to have ways to help these patients out beyond physical therapy that may go ahead and affect the nerves themselves. So what we can go to the next slide, please. What we're focusing on here is the data behind this, right? So we have systematic reviews, meta-analysis, sham-controlled RCTs that have benefits to it. We already discussed the Almeida study, which has inherent flaws, including studies that were not directed towards genicular nerve ablation the way that we commonly practice it with 3 or 4 or more targets. In addition, we have randomized control trials, hyaluronic acid compared to genicular nerve ablation, as well as intra-articular corticosteroid at 6, 12, 20-month follow-up. So that's 6 studies that were generated, 2 randomized control trials with long-term follow-up showing significant benefit. So I think it's important to keep that in mind. From a personal perspective, most of our referrals come from orthopedic surgery. As interventional radiologists, we're primarily consultants, which also means that the orthopedic surgical community has a lot of faith and a lot of good results from this. In fact, one of the main authors on those randomized control trials is an orthopedic surgeon. Let's go to the next. All right, so we can go into a little bit more detail of an RFA technology at a later discussion if we want to. Go to the next slide. And there's, again, plenty of evidence for GNA. Now, in our practice, as Dr. Resnick mentioned, we typically do a nerve block first to test the nerve. And if you have a 50% reduction or more, we do the ablation. What that means is that not necessarily everyone that gets a block is going to benefit enough to have the ablation. So we are not, often just kind of going into the ablation in terms of if you look at it from a cost-saving perspective. And again, if someone doesn't benefit from a block, we're not going to go to the next step. So we're going to try to think about things that can benefit the patient. All right, let's go to the next. All right, so this is again going into some of the data that has already been mentioned. Next. All right, pudendal neurolysis. Next, great. So there are plenty of studies, as well as a very recent RCT
2 minutes
demonstrating demonstrating the benefit for pudendal nerve targeting. We do this very frequently for a lot of patients, especially those who can't leave the hospital in a chronic pain setting, certainly for the outpatient setting as well. So again, most of us will test this nerve first under our practice CT or fluoro guidance. If they get a 50% reduction or more of pain, then we'll go ahead and we'll do the ablation. Eliminating this as an option for these patients really puts them at high risk for opiate dependence. The reason is there's not many good options at that point for these patients. Potentially you could do a nerve stimulator. However, the nerve stimulators with trials are also, subject to an LCD. So I think that if we start cutting these things away, what will happen is the progress that's been made, has been alluded to, in reduction of opiates is going to get reversed, and we're going to see a higher rate of opiate dependence. Next. And next. And this is just a brief patient experience just for the sake of showing what we see on the day-to-day. Again, 75-year-old, partial TKA. Next slide. This is what it looks like on X-ray. Next slide. And this is someone who does not and cannot have any replacement. Next slide at this point. That's what the block looks like. We do under fluoroscopy. It's minimally invasive. It's in and out. Next slide. And if the patient does well, then we proceed to RFA. So next slide. And this is just to show you what this looks like. It's 17 gauge needles, and this is able to treat the patient. Next slide. And then same thing on the left. Next slide. Next slide. And this is what we see. Next slide. More importantly, we follow up these patients. We make sure that their pain is reduced. These patients can then, if let's say weight loss is an issue, barring them from surgery, they can enter a weight loss program. They weren't able to do that before because of the knee pain. So I think it's important to remember what we're trying to do with a lot of these procedures is we are not obviously, reversing something that's been done to a patient. We're helping them regain a quality of life so they can have a longer term benefit from everything that we're doing.
Thank you. I'm sorry, your time is up.
Thank you so much for your presentation. Additional comments and any clinical literature can be sent to policycomments@wpsic.com. Are there any comments from the medical directors? Hearing none, I'm going to move then to our last presenter for the day. Is Dr. Rajiv Tewari from Optum Bone and Spine from Carmel, Indiana. Please, Dr. Tewari, go ahead with your presentation and disclose any conflict of interest.
And Dr. Tewari, you are on mute.
Thank you for that. Sorry. Well, thank you for allowing me to present today. My name is Raj Tewari. I'm an anesthesiologist and an interventional pain specialist. I practice in Carmel, Indiana. The only disclosure is that I do teach educational events for Avanos. So just, in terms of my personal experience, I have 28 years of experience in pain management. I've seen countless patients after joint RFA and the improvements that they can experience. These improvements can be improved functionality, return to work, weight loss, decreased medication utilization. But I think that it's important to realize that there is an important gap between the treatment of conservative treatments such as physical therapy and injections and joint replacement. And I think that, total joint RFA is an important segue for patients to get excellent care without engaging in medication management and opioids. So the case for RFA, it's not just anecdotal though, and there's a large body of high quality research supporting its safety and efficacy. Next slide. So I really want to address, the limitations of the LCD and why I think that the LCD would be really negative for the patients of America. When you look at the LCD evidence, there was an inappropriate grouping of techniques that combined all forms of RFA and did not distinguish what types of RFAs were performed on patients, nor their mechanisms, nor their long-term outcomes. And to view different techniques such as pulsed RFA, thermal RFA, and cooled RFA as all identical certainly is not appropriate. It certainly didn't address, all the clinical guidelines from the multiple pain societies that were even represented here today. And the non-pain societies were given actually more credence. You know, it really, and people have addressed the Almeida study that was such a strong point of evidence for the LCD. And it's really important to understand that a meta-analysis that was done with that Almeida study is inappropriate and unsuitable for the heterogeneous data that was presented in that study. It had significant limitations. It downgraded high-quality studies, double-blinded RCTs, and it lacked subgroup analysis, which, unless you do that for heterogeneous data, is certainly unsuitable to view the validity of that data. And the other thing about the LCD is that it really misses newly published data that supports RFA for knee osteoarthritis. Next slide. So what is reasonable and necessary is defined by CMS. So we're dealing with a therapy that's safe and effective. There's nothing experimental or investigational about this therapy. The questions of safety and efficacy are certainly unclear as to why they're stated in the LCD as such. The FDA does approve of COOLIEF ablation of the knee specifically. It is completely within the accepted standards of medical practice and care across the country. And when provided by highly qualified, highly trained individuals, we really do provide a lot of benefit to these patients. Next slide. So in terms of safety and being effective, RFA devices have had FDA clearance. It does have a specific FDA granted specific label claim. There's level 1 randomized controlled trials that verify its efficacy. There's long duration trials. There's single arm prospective studies. There's real world retrospective studies. There's systematic reviews, society guidelines, and none of these were actually included in the LCD when they did do the analysis for RFA. Next slide. There's nothing experimental or investigational. The RFA device was granted clearance by the FDA previously. There is COOLIEF for the knee, which has been approved by the FDA, and RFA for chronic knee pain has been performed safely for decades across the country and really around the world. Next slide. So this is with accepted standards of medical practice. It's been published across multiple orthopedic, radiology, and pain journals. There's consensus societal guidelines from the societies that presented today, ASPEN, and even internationally across multiple countries that view genicular RFA as reasonable with consensus strong data supporting its efficacy. Next slide. So non-opioid solutions to delay or avoid surgery are essential, that we have these interim solutions for patients where interventional injections such as corticosteroids or HA injections, hyaluronic acid injections, will not provide long enough pain relief for some patients that are in the gap between surgery or that need to be strengthened prior to surgery and need to have pain relief without use of opioids. Next slide. RFA of the knee is superior to HA and steroid injections with longer durations of actions and clinically superior efficacy in terms of the degree of pain relief. Next slide. There was a really good systematic review that was recently published in August of this year, which identified RFA recipients. And really the data does support, if you look along at the 6-month follow-up slide, that large lesion RFA lesions of the knee, especially with techniques such as cooled radiofrequency ablation, is highly effective in reducing knee pain in the majority of patients with osteoarthritis. And large lesions really do give at least moderate to a high degree of pain relief for an extended duration of time. Next slide. Currently, patients have very few options. And, my fear and the fear of clinicians across the country is that after this LCD and the inability to receive RFA of joint-related disease, that again, opioids would be used to manage these patients, which is clearly against governmental directives. and with a long track record of, doing patients a disservice. RFA addresses this gap with, a non-opioid, cost-effective, long-lasting improvement in pain function and quality of life. We want patients, to have that ability to have excellent pain relief and perhaps even avert joint replacement if that's possible. Next slide. And that's the end of my discussion.
Thank you for your presentation. Are there any comments from the medical directors? Okay, hearing none, now we're going to move to the people that have their hand up, but before we allow them to speak, I want to clarify again that the intent of this meeting is to hear comments on the proposed LCD and the evidence where it was based. Any questions or will be addressed on the response to comment document once the LCD is finalized. So taking that in mind, we'll then open up for the people that had their hand up in the chat, starting with Dr. Asokumar Bhuvenadrian, and apologies if I didn't said that correctly. Could you go ahead express any conflict of interest and go ahead with your comments?
Thank you so much, and good afternoon, everybody. I'm Dr. Asokumar Bhuvenadrian, and you were pretty close to my pronunciation. And I'm talking on behalf of the American Society of Anesthesiologists, which represents 55,000 members, and the American Society of Regional Anesthesia, which represents more than 6,000 pain physicians as well. I'm here to speak on the LCD and the strong evidence as outlined by several of them. In fact, if you look, I was one of the members of the CDC guidelines for opioids back in 2009, and we heard testimony not only by physicians, but by patients who had deaths from their family members from the opioid epidemic. These current treatment modalities that we have adapted have actually curtailed the opioid epidemic, and I'm proud to say I was able to help with the CDC in putting some of these guidelines in place, including the peripheral nerve blocks that have been mentioned in the LCD that have decreased the opioid epidemic and in fact come to a stable level. I would like to spend 2 minutes talking about the radio frequency RFA, which has been delineated several times clearly. I was one of the initial authors back in 2015 who did the cadaver studies to delineate some of the nerve findings of the knee, and then proceeded to do radio frequency denervation studies after that to demonstrate the efficacy. In fact, radio frequency of the knee was in fact got a category CPT code because we have a lot of evidence, randomized controlled trials, and in fact has a CPT code because of the evidence demonstrated. So turning this dial back into future or past sense of demonstrating that saying there's no evidence would be contradictory to the previous evidence that has been demonstrated very clearly. Furthermore, I don't want to repeat what people said. Patients who have this knee surgeries also have an incidence of chronic pain. In fact, the incidence of chronic pain after knee replacements ranges between 10 to 30%, and we are conducting a large NIH-funded $40 million study across the country to determine the factors why patients develop chronic pain after knee surgery. And one of the treatment modalities that we have adapted is the radio frequency of the knee. Turning off to the topic of CRPS and stellate ganglion blocks, CRPS is a very unique condition, and I'm one of the authors of the guidelines for the diagnostic criteria that was developed by the Budapest criteria for CRPS. The disease is extremely challenging, and in fact, there's not a single medication that is approved by FDA for CRPS because it is very diverse in studies, study population, and presentation. And as such, any treatment modality that has been recommended as guidelines should be adapted. The alternative from my evaluations of several hundreds of patients in my practice of 25 years of CRPS treatment of patients, some of them have committed to them that either they commit suicide or they will kill themselves because the pain is so much debilitating if they cannot have their treatment modalities such as stellate ganglion blocks and other modalities that are available to these patients. It's my urge that, as proposed by others, that we reconsider this LCD and put all these LCDs on hold until further discussion can happen so that our patients could continue to benefit from the treatment modalities that we have been providing for years. Thank you.
Thank you so much for your comments and for being so gracious of saying that I was closing the pronunciation of your last name. That was greatly appreciated. So you can send any additional comments to our mailbox. Let's go to the next hand that is up. That is Dr. Max Ekman.
And I apologize, this is Administrative Assistant Rich. We can take about 15 more minutes of comments before we do have to move on to the other LCDs that are up for discussion today. So just keep that in mind when giving your comments.
Okay, thank you. I'll try to be brief. Thank you for this opportunity. My name is Dr. Max Ekman. I'm an anesthesiologist and pain physician. Like Dr. Bhuvanendran, I'm speaking on behalf of the American Society of Anesthesiologists, and much of this content has been well covered, so I just wanted to highlight a few things. The ASA is supportive of patient access for appropriate use of peripheral nerve blocks and ablation, and generally supports the comments that you have heard today from the standpoint of clinicians. And the ASA will be submitting a formal comment letter that will provide more detailed information supporting the use of peripheral nerve blocks and ablation. I also just wanted to add a few things as a clinician. The variety of peripheral nerve diseases is extremely diverse. Any nerve in the body can be affected. So therefore, while some conditions have been well studied, like the spine and the paradigm for peripheral nerve block as a diagnostic step and ablation have been well vetted, it's not very practical to study these other rare conditions to that level of rigor. But where we've been able to do that, it's been clearly shown that peripheral nerve blocks remain a gold standard diagnostic step for many decades. So in fact, part of the diagnosis of these conditions requires a successful peripheral nerve block. So if we take that away, then we lose the ability to guide care for other healthcare professionals like surgeons and oncologists and others who are trying to determine what the cause of pain is. And this may result in other unnecessary treatments, as you've heard. And furthermore, just for practicing the space for many years now, I've been in a practice that is not incentivized by production, and my patients have requested these procedures, and I'm not incentivized to do them one way or the other. So I just wanted to share that with you, that in the real world, these can be very beneficial, because the truth is most medications are not very effective for chronic pain, and many patients are intolerant of them, and these procedures provide an alternative to those medications. Thank you.
Thank you for your comment. Let's go to the next commenter that has his hand up. Is Hilton Kaplan. Please, no, sorry. The next is a telephone number. Is please the person on 210-857, 1884, identify yourself and express any conflict of interest. Proceed with your comments. The telephone number that has the right hand up, number 1.
*6 to unmute your phone. That is telephone number ending in 1884.
Okay, so let's go then to now Hilton Kaplan. Go ahead and comment, please. Stating any conflict of interest. Thank you.
Thanks. I'm the Chief Medical Officer at Avanos, and I'm speaking on behalf of the Coalition for Interventional Pain Treatment, which represents 7 manufacturers of RFA and cryoneurolysis technologies that have come together as a group. So that's Abbott, Avanos, Boston Scientific, Medtronic, Pacira, Stratus, and Stryker. And we really second what the KOLs have all said today about, and the societies, particularly Drs. Tewari and Kalia, and I mean, everyone has supplied the data that, you know, we would be supplying as well. But in summary, you know, we have three reasons that we think the proposed LCD should be rescinded at the moment. One is that it runs counter to the federal initiatives around opioids. Two, it creates the significant gap in between oral medication or opioids and surgery. And three, you know, there's new high quality evidence that's come out subsequent to the initial meetings that should now be considered. And there are also guidelines that support this and that are imminent. Thank you very much.
Thank you for your comments. Really appreciate it. Let's go to the next person, that is Mahendra Sanapati. Go ahead, state any conflict of interest and proceed to give your comments.
Yes, thanks for giving me the opportunity to comment on this LCD. I'm Mahendra Sanapati. I'm the current president of American Society of Interventional Pain Physicians, which represents more than 4,000 members. And our society has been very active in interventional pain management field for many years. And we actually are involved in many guidelines and LCDs for many years. So I have been in private practice for 27 years, treating a lot of Medicare patients. And these procedures are very helpful in our patients. The Medicare population, they have a lot of these knee pains, hip pains, back pain. And my partners also in the practice, they perform these procedures. And most of them perform about 90% of these procedures. And patients are very happy, and they keep them very functional, mobile, and able to perform their daily activities. So I'm wondering, you know, if we lose these procedures, what happens to all these patients? We are getting them going on a daily basis. And this LCD, unfortunately, seems to eliminate nearly all peripheral nerve blocks and limiting the coverage only to few procedures, trigeminal and medial neuropathy and Morton's neuroma. Of course, this is going to, again, as my other colleagues have commented, it's going to increase cost by involving major surgeries and also putting these patients on opioids and at high risk. So I would recommend some options. First option we like is to withdraw this LCD and involve a multidisciplinary expert panel to revise these criteria based on current evidence and real world practice. And the second recommendation I would consider is, like we have done over the years with other procedures, like with facet joint pain and sacroiliac joint pain and even in knee pain, to allow diagnostic blocks. And if the two diagnostic blocks offer more than 50% pain relief temporarily with functional improvement, then we can proceed with radiofrequency ablation on these patients. So I'm trying to, make this easy and more practical and help all our Medicare pain patients. And also would be nice to approve up to 4 therapeutic blocks per year. That's 1 block every 3 months if they are not candidates for radiofrequency ablation. So thanks for taking my comments, and I appreciate all this input, and my colleagues have made excellent points. Thanks for this opportunity.
Thank you, Doctor. We appreciate your comments. Let's move to the second hand up right now. That is Angie Barrevel. Go ahead and state your name correctly with any conflict of interest.
Thank you. Not to worry. We all have difficult names. Again, my name is Dr. Antje Barreveld. I am president of the American Academy of Pain Medicine, and I have no conflicts of interest relevant to this. I'm hearing an echo. Are you guys okay? Can you hear me okay?
I fixed it. I had to mute someone.
Okay. All right. Thank you. So again, I'm a pain medicine physician in the Boston area and president of the American Academy of Pain Medicine, and that represents over 2,500 members, interdisciplinary members, and stakeholders over 10,000, from pain psychology to interventional pain physicians. And I applaud all of my colleagues for your really important comments. I wanted to give patient examples. These are patients of mine that are going to be impacted if this LCD were to go through. And the American Academy of Pain Medicine strongly, strongly urges that we put this on hold and again have this discussion together. My first patient is Anna. She has severe vulvodynia from an autoimmune disorder with skin erosions that have her feeling this constant burning pain in her vagina. Before she came to see me for pudendal nerve blocks about 3 to 4 times a year, she couldn't sit, she wasn't working, she could not wear underwear, she couldn't wear pants, she couldn't be part of her family's day-to-day life. She was on high doses of sedating medications and still had pain. Since we started the nerve blocks, she's a totally different person. She's not in and out of the doctor's offices, less reliant on dependency-forming medications. My other patient, who I just saw this week, he's 92 years old. He's a veteran. I will call him David. He has severe knee pain and arthritis. He's 92. No one wants to do a knee replacement for him, but he's incredibly active and clear-minded. He cannot walk because of the knee pain, and now is diagnosed with throat cancer and needs to be able to go to the hospital to get treatments so that he can swallow food. The genicular nerve blocks and radiofrequency ablation that I have done for him this week is something that keeps him going. And then finally, I have a patient, Sue, who is on chronic steroids for rheumatoid arthritis. She is on very high doses of opioids and has been in and out of the hospital over the past few years because of pain. And since I started nerve blocks that have addressed many of her fractures, including intercostal nerve blocks for rib fractures, she has not had a single hospitalization for acute on chronic pains. And so I urge you to prevent more surgeries, prevent reliance on medications, including opioids, prevent increased emergency room visits and the costs related to hospitalizations and the costs related to increased office visits if these nerve blocks go away. Our patients depend on them, rely on them, and for many of them, these nerve blocks are life-changing. So thank you for considering our patients.
And thank you for your comments and for your commitment to our Medicare beneficiaries. That's greatly appreciated. So let's go to the last commenter here. Is telephone number ending on 1884. Let's see, go ahead and identify yourself and state any conflict of interest, please.
And you can press *6 to unmute.
Can you hear me? It's Dr. Mina?
Yes, we can hear you. Go ahead.
Thank you so much. Yes, I'm Meg Mina, anesthesia and pain management. I'm representing the American Society of Anesthesia. My colleagues, Dr. Ekman, Dr. Devindaran, preceded the talk. I agree completely with a lot of the presenters. I've been in practice for 25 years. And in summary, and I know the time is coming up, we do have multiple patients that are Medicare beneficiaries that have very well been treated with nerve blocks and then successfully after that with neurolysis with a radiofrequency or neurolysis. So in summary, to be standing with my colleagues who commented earlier and the different societies as part of the ASA and the ASRA, American Society of Regional Anesthesia, we do request this LCD to be placed on withhold to continue coverage of the peripheral nerve blocks, including neurolysis, and definitely work on a guidelines, a consensus multi-society group that can provide wide range of guidelines to have these patients undergo these procedures. These are my comments. Dr. Mina, again, representing ASA and American Society of Regional Anesthesia. Thank you all.
And thank you for your comments and for your commitment to our Medicare beneficiaries. Any additional comments can be submitted in writing through the comment policy mailbox that I put on the chat. We greatly appreciate your comments and the previous presentations. Let's move them forward with our meeting. Now we will discuss the other proposed policies for this meeting. There are no commenters for this, no presenters for these policies. So we are going to move to DL 40272, that is MolDX biomarker testing for risk stratification in metabolic dysfunction associated steatic liver disease and metabolic dysfunction associated steatohepatitis. The comment period of this LCD ends on October 31, 2025, and the lead CMD is Dr. Nachowski. Dr. Nachowski, please proceed and present the policy.
Thank you so very much, Dr. Schoening. I'm going to try to add brevity to this because we've had a long meeting already. I do have 3 total policies that are MolDX related. And I just want to give a very high brief intro to what is the molecular diagnostic program for all of you here. The molecular diagnostic program, it is a multi-jurisdictional, meaning multi-MAC program. It is not one. It's comprised of multiple MACs that are all involved in the research and the development of policy that is related to molecular diagnostic tests and complex proteomics. This program is under CMS regulation and guidance. This program has CMDs with multiple specialties and multiple credentials, including clinical pathologists, PhDs in molecular and clinical genetics, etc., that collaborate together in policy development. All of the participating MACs adopt the same finalized policy with the same content and title of the LCD, except our LCD ID number will be different. Just so that you get an idea of what it is. So there are multiple MACs involved. Regarding this policy, DL 40272, with the long name that Dr. Schoening so kindly stated, in regards to this one, this is a coverage policy. This policy describes coverage for molecular or proteomic biomarker test for the diagnosis and the management of liver fibrosis in the setting of metabolic dysfunction associated steatotic liver disease, or MASLD, as you may want to call it, as well as metabolic dysfunction associated steatohepatitis, and that is MASH. I'm going to have people repeat that 10 times rapidly at the end of this meeting, see if they pass. But in accordance with the American Society for the Study of Liver Disease guidance, the term MASLD will be used as a replacement for the non-alcoholic fatty liver disease, or NAFLD, and MASH as a replacement for non-alcoholic steatohepatitis, or NASH. As comparisons have found a near complete overlap between the recently defined MASLD population and the historical NAFLD population, results from biomarker validation studies among these patients will be considered applicable to the patients in this policy for MASLD and MASH. Other types of chronic liver disease, including but not limited to metabolic dysfunction and alcohol-associated liver disease, or viral hepatitis and autoimmune hepatitis, are considered separate entities with distinct etiologies, natural histories, and management, and therefore they're not going to be encompassed in this policy. So major criteria for coverage in regards to this policy is that this molecular or proteomic biomarker for the assessment of risk of liver fibrosis in the setting of MASLD or MASH is considered reasonable and necessary when all of the following criteria are met. Number one, the patient is an adult with clinical suspicion or diagnosis of MASLD or MASH, which is based on current professional society guidelines. You know, as an example, the American Gastroenterology Association or the American Association of Clinical Endocrinologists are a couple examples. Number 2, a primary risk assessment based on non-molecular proteomic laboratory testing as outlined by the consensus guidelines does not indicate a low risk. Number 3, liver stiffness measurement, or LSM, by imaging, example, vibration controlled transient elastography or magnetic resonance elastography is indeterminate or is not performed. The results of the test of these tests in this possibility will be used to directly aid in pending management decisions. Example, referring them to a specialist, performance of a liver biopsy, eligibility for pharmacological therapy, as documented in the patient's medical record. Testing is not performed more than once within a 12-month period, nor within 12 months following a liver biopsy. Those are the major things that I wanted to point out in regards to this policy. Any questions or comments? Or Dr. Shaney, do you want me to present all 3 of my policies and you'll reserve time at the end? It is your discretion as moderator.
Oh, okay, so I think you will prefer to present the 3 policies, and then we will allow the commenters to comment. So let's go to the next policy, that is DL40274. Go ahead, Dr. Nachowski.
Thank you so much. So this one is genetic testing for hereditary thrombophilia. Okay, again, compared to the prior one that I stated, these last 2 policies, open comment period is from September 25th, 2025 through November 8th, 2025. Okay, coverage indications. This policy defines, again, it is a coverage policy for lab developed tests, FDA cleared or FDA approved clinical laboratory tests for hereditary thrombophilia, including next generation sequencing test. This policy scope is specific for hereditary germline testing. The major criteria for coverage with this one is the genetic testing for hereditary thrombophilia is covered when all of the following are met. Number 1, the patient presents with venous thromboembolism or VTE, and at least one of the following is true. Either A, the patient presents with VTE that is associated with non-surgical major transient or hormonal risk factors as defined by the American Society of Hematology guidelines, or the patient presents with cerebral or splanchnic venous thromboembolism in settings where short-term primary treatment is the standard of care, meaning settings where anticoagulation would otherwise be discontinued, and testing will inform the decision for long-term anticoagulation. That's the first criteria. Second criteria is genetic testing will guide VTE clinical management, particularly in regards to the duration of anticoagulation. Number 3, the test performed includes at least the minimum genetic content, be it genes or genetic variants, with definitive or well-established guideline-based evidence as determined by the American Society of Hematology, required for clinical decision-making for its intended use that can be reasonably detected by the test. A single variant may be tested if it's the only variant considered to be reasonable and necessary for a patient that is a known familiar variant. And lastly, that the test does not include additional genetic content that is not properly validated or of unclear clinical validity or utility, such that there could be a reasonable expectation of misutilization by the patient or treating physician, resulting in impaired patient outcomes. So that is policy number 2. My last policy is draft 40278. non-next generation sequencing targeted molecular panel test for predictive testing in cancer. Again, your comments will be taken up until November 8th, 2025. This also is a coverage policy. So this policy describes and clarifies coverage for molecular or proteomic panel test for non-next generation sequencing targeted molecular panel test for predictive testing in cancer. You've seen how I stress the word non versus next generation. The determination outlines the medical necessity, indications, limitations, and required documentation for biomarker testing to assure appropriate patient population selection and effective utilization. Major criteria for this policy is that the patient has a diagnosis of cancer for which molecular testing of the tumor will inform treatment. That's one of the requirements. Second is at least one of the following is true. Testing by next generation sequence or NGS is not feasible in this case, or will likely fail based upon the specimen type or the tumor content. B, that the next generation sequencing or NGS is not required by national consensus guidelines to inform medical management decisions, and testing by a non-SGS method will provide a rapid result that allows for the prompt and timely management of this patient. Or C, that the test accurately identifies known, common, and necessary predictive and actionable biomarkers that can safely preclude unnecessary NGS testing, reduce NGS use in patients for whom the treatment plan would not likely be altered. Number 3, the patient has been previously tested by a molecular panel test for the same cancer indication. I'm sorry, please forgive me. It's that the patient has not been previously tested by a molecular panel test for the same cancer indication for the same genetic content. I think those are the major things. The rest you can rely on the policy. But these are the 3 MolDX policies that I'm presenting. Now I will leave it open if there are any comments.
And raise hand or press the *5 if you would like to comment on your touch tone phone, and we'll allow comments. I see there are no comments on any of these 3 molecular diagnostics policies.
Thank you, Rich. In conclusion, I just want to say, thank goodness that mine were very simple. I want to thank all the presenters here. I think it was a very valuable, and I know that Dr. Shanin will have closing remarks. I just wanted to make a few remarks and keep it to the end of this meeting. But truly, all the presenters, our MAC truly presents all the data that you provide us. We are here to help the beneficiaries. We are not the enemy of the beneficiary. We want the best medical literature out there to help us write the best policy. That is why we have meetings that are sometimes called subject matter experts for evidentiary CAC meetings. That is why we have this open meeting, so that we can come to our providers who are in the community, who are the forefront. I always say they're on the front line. We appreciate your comments. We appreciate that they are supported by current medical literature. This data is all taken back, where when it is a multi-jurisdictional work group, we will be getting data from all the multiple MACs, utilize that data so that we can present the best policy available for our beneficiaries, supported by current medical literature data and within the realms and the guidance of CMS. We truly, again, I'd like to say I appreciate all the presenters. I appreciate that the majority of you remained very professional and you provided the literature there. But I do want to make one last comment that we are here to help the beneficiary. Any inflammatory comments not supported by medical literature really is not beneficial and appropriate in an open meeting, and it will not be conducive at all for us to make the best policy out there. But otherwise, I thank you all again, taking your time from a busy schedule. We all know that we have all been in private practice or in academia centers. So for you to take time to present data so that we can provide a policy or multiple policies for our beneficiaries is greatly appreciated. Thank you very much for your time. And Dr. Schoening, I'm going to direct it back to you.
So thank you, Dr. Nachowski, and thank you for those excellent closing remarks. Do any of my fellow CMDs want to make a closing remark? Hearing none, then I would just say thank you for making this a great open meeting and for your interest in our Medicare beneficiaries and the Medicare program and on evidence-based medicine. Hearing that there are no further comments, I will then give this meeting adjourned today, October 22nd, 2025 at 2:45 p.m. Central Time. Thank you for attending the proposed local coverage determination open meeting from WPS. Have a beautiful day.